Welcome back to Mostly True Psychiatry with Dr. Mellon. Today we're going to be talking about the basic scaffolding for things you should think about or keep on your mind when it comes to treating schizophrenia. The next few videos will be actually on specifics for mostly second, third generation antipsychotics and their side effects and how they compare and all that good stuff. So today we're going to talk about diagnosis, treatment of schizophrenia, general information. So first and foremost, nothing works when it comes to treatment with schizophrenia unless you get the pill to the mouth and it shows up every day, unless it's a long-acting injectable. You must have frequent visits, simple plans, and you're going to need help from family or friends because the patients, they classically have poor insight. They intellectually become more and more kind of concrete thinking, stiff, have difficulties managing, their activities of daily living. Delusions become a problem. So non-compliance is basically the role. These patients notoriously will not continue medications, even if they say, oh yeah, it helped a lot, and then they just stop because they're better kind of thing. I would strongly encourage if you're outpatient, you actually see them every couple weeks for a little while till you're pretty sure you've got the symptoms under control. And a lot of that is psychoeducation and working with the family and stuff to get more buy-in. Any plan that says taper over 4 weeks and cross taper up is going to fail. It has to be simple. They won't follow the instructions. It won't work. It's just my opinion on it from my working with it. Realize that you're treating negative symptoms. You're treating positive symptoms. You're not treating negative symptoms. There's a lot of kind of confusion in this, especially with the older psychiatrists from when they learned their information. So kind of some of the reasonings or ideas of that is from like a 2013 meta-analysis when they looked at about 170 trials, over 5,000 people on the treatment arm, over 5,000 placebo arm total. There was some statistically significant evidence of benefit for helping improve negative symptoms, those anhedonia, that not interactive, not showing facial expressions, their flat affect, all that stuff. There was some statistically significant, like you had a 0.1 change on a question scale kind of nonsense, nothing clinically relevant. I'll talk about a few quick categories and where people used to think it works and stuff, and it's just not true. So first and foremost, let's start with where are the antipsychotics? So early research, everybody got excited. Every time there's a new drug in psychiatry, they go crazy and it solves everything and does everything, and it just never pans out, or a lot of times doesn't. So early research was saying all the atypicals were helping have those negative symptoms. The subsequent analysis, and as the next 10 years went on, 15 years, absolutely did not support that. At best, if you're super generous, the effect size is this big. Like it just may be better than a sugar pill. Maybe. They've tried to compare first generation versus second generation as a class. No support of helping either symptoms. I can't spell, so that's their type. There we go. Symptoms. And then they start chasing the third generation, what I call third generation. Not everybody likes these terms, but starting with the things like aripiprazole and buprenorphine and all this stuff. Like people are trying to promote the newest, or not buprenorphine, sorry, my mind's telling me brexpiprazole. These drugs, they're trying to promote that they'll like help more for negative symptoms. There's no reasoning that they're going to hitting 5-HT1A or doing a different dopamine 3-4, doing whatever. None of it has any effect for negative symptoms. People have chased antidepressants because they're like, oh, they're depressed, and the whole schizoaffective angle. I'm not going to get into that argument right now, but there's 2 out of 3 meta-analysis following for negative symptoms with antidepressants didn't show that there was anything clinically significant as far as helping negative symptoms. Despite this, still routinely done. Often schizoaffective disorder is the concept, and they're saying they're depressed. So they're treating something different. People love inflammation ideas in psychiatry, so people have been chasing the idea of inflammation since 100 years, since immunology was even a thing, steroids were a thing, all this stuff, and saying inflammation, immunology, part of that to do with the process of schizophrenia affecting, the glial cells. Sorry, I'm too tired to be doing this, I guess, today. Affecting the glial cells and inflammation and things like that. There was originally some promising evidence, just early evidence. There's always promising evidence. It just means that it's like N4 had a positive benefit. Minocycline was a big one because there is like a general like meta-analysis that was like saying that it does help negative symptoms. But those weren't even the primary outcome in those studies, which becomes a real big problem. It's just like they're like, we'll ask these other things, and not what the study was actually designed to test. So this was promising evidence to research it, right? That's super reasonable. So the two big trials that started up were, I think one is in Europe, one's in Canada or the US or something, I don't remember. So there was the Benamin, so I guess like benefit minocycline or something, benefits minocycline. I guess it says right there. I should read it. So this was a big study done. It was a double-blind, randomized controlled trial. It completed in 2018. They were giving 300 milligrams for a year. They were doing PANS. They were testing it, for the 4 times over that process. Each arm had 100 people-ish. No benefits. It was the same as the sugar pill. There's an ongoing trial right now. I think might be the European one, which is called Minos, and we'll see what it turns out. If that'll be the decision point. If that also says no benefit, it's not likely that those earlier meta-analysis mattered, because when they actually tested directly, if 2 randomized placebo-controlled trials, large, well-done studies don't support it, then it's probably not helpful. So what else do we got? So when you're treating, basic concept is, it's D2 inhibition. There's a kind of a general concept that you're trying to get 80-ish% blockade, clozapine being the obvious counterexample. Quetiapine being another one. It's a little weird because it lets go so quickly. It doesn't tend to be over anywhere near that either. But that blocking D2 helps. Stop positive symptoms, specifically just auditory and visual hallucinations. You reduce those, the delusions don't. At least from my point of view, that's why the delusions aren't get helped, because you don't have something talking to you the whole time saying you're going to be poisoned. You have delusions of people are trying to hurt you. So you should you start with the second generation, just what you're thinking of as an atypical, clozapine, olanzapine, risperidone, whatever, go all the way through. If one fails, you go to the next one. Next one fails, go to the next one. Just keep trying them. Go one after the other. Don't double them. Never double them. It's bad practice. It's almost never the right answer. If you're on your 5th one, you're on your 5th one. Whatever. You get to go to the fancy new drugs eventually. And basically, it's just because you're trying to avoid the extrapyramidal side effects. You don't want a person to have permanent weird motions or doing like facial stuff forever. So the current evidence says never stop. You start antipsychotics with schizophrenia and you continue them till they die. Some people I've heard thinking weird stuff like it's going to kill you 20 years early. It's going to cause you to have liver failure. It's going to do all this weird stuff. It's not true. I don't think it's true. I mean, it's just they're going to die young if you don't treat it. They're going to end up in jail. I mean, they're going to be victims of crimes. Like all sorts of stuff's going to happen. So, but actual long-term antipsychotic use increases their life expectancy, their survivalship. Relapse does not decrease with a function of time. They've done a bunch of huge studies, like Finland, the Scandinavian countries, right? Medicine loves them because they track everybody's medical history and it makes them the best thing ever, I guess. So they followed people for 40 years, and they defined relapse as being hospitalized again. They set a hazard ratio to 0, and then if you're continually taking antipsychotics and they let people stop and say, do you relapse? They relapsed at 1 year. They relapsed after 2 years. They relapsed after 5 years. They relapsed after like 8 years. You're going to relapse. It doesn't matter when you stop the drugs. It's the same concept. It's not going to get better. You're not going to wait 5 years and then do a trial off and that might be okay. It doesn't matter when you stop. You're still going to have a problem. There's other studies that have kind of supported this. I don't think I'm going to beat a dead horse on that one. Just all the evidence supports you just start a med, never stop. The expected response concept of what you're treating is initially it's just kind of sedating, calming. So it's going to reduce the first week. You're just trying to cut down agitation, hostility, aggression. Maybe it'll sleep. It's a sedative, right? A little bit, especially depends on which one you pick. Sleep better appetite. Over the next month, it'll continue to improve their kind of paranoid hallucinations, bizarre behavior. Some benefits over the next 3-4 months with the delusions. This I'm going to delete now because since I've done more evidence, it's just not true. And some doctors really hope that you're going to have improvement with the cognitive symptoms. So these are the general kind of treatment ideas. The cognitive symptoms, I doubt. If anything, it's that there's the idea you have stepwise damage to the brain with each major psychotic episode. Because some people are continuously, basically with schizophrenia, some people are continuously fully psychotic. It's hard to ever break it. Some people it's very, very minor and it takes a long time before it's even obvious. Other people are like bad episodes, kind of crush down. They seem to do okay and then they fall apart. If that's that last version is what you're looking at, maybe if you can keep them from the big episodes, maybe it does less brain damage or it's going on general cognitive decline, and at which point treatment would help improve cognitive performance basically just by not having major episodes. All right, so hopefully that was helpful. I'm going to have water, a little more energy in the next round. It's been mostly True Psychiatry. I'll see you guys later.